Okay, yeah, so the recording has started and I would like to say a warm welcome to everyone. Seems like there's a lot of interest in Scotland and in healthcare innovation in Scotland. So we're really looking forward to this webinar, and I'm going to show you the agenda for the day. So we have a short introduction here, and then we will mostly, of course, listen to Nessa Barry, who's the international engagement, works for the International Engagement Directorate of the Health and Social Care Finance in Scottish government. Yeah, at the end, we will also present the upcoming delegation trip, which is planned for the 9th and 10th of April. But Marianne, do you want to say hi and present yourself?
Yeah, hi, I'm Mariana Beaufries. I am working for Scottish Development International. I am the lead on life sciences in the Nordics. So what I do is that I help Scottish companies that want to export to the Nordics and only within life sciences. Good to meet you all.
Great to have you here and to be collaborating with you and the rest of the team from Scotland, of course. My name is Anna Riby and I'm a regional director at SweCare. And yeah, I think most of you already know SweCare, but if not, we're a semi-governmental foundation. So we work very closely with the Minister of Health and Social Affairs and do delegation trips together with them. And also, like this one, will be without political presence, but hopefully someone from the ministry will join. And we do a lot of webinars on markets or thematic topics and networking and communicate about Swedish life science in general. So with that, I would just like to welcome Nessa once again, and I will stop sharing my screen and ask you to share yours.
Okay.
Let me see if I can manage to not share any longer. Huh. Or can you just take over? It doesn't really...
Let me try.
Yeah, looks like something's happening. Great. We see your presentation, but not in presentation mode.
Okay, it's just slowly.
Yeah.
Sorry. Right, let me know if that's okay.
Yeah, now it's
Super.
good.
Okay, thank you. And thank you very much to Marianne initially and David for inviting me to speak to you this morning. As you've heard, I'm Nessa Barry. I work with Scottish Government's Digital Health and Care Directorate. Our little bit of the team in Scottish Government focuses on international engagement. And as a result, we get to be involved in a number of programs and initiatives, both in Scotland and out with Scotland. So we work quite a bit with European and other international colleagues. So I've been asked this morning just to give you a bit of background for the Scottish health and care system. So I'm going to focus on that, and hopefully that will provide some useful background and insight into the conversations you're going to have further on down the road. So hopefully this information is not old news to most of you, and that you provide it useful. So just to get through the practicalities really of the Scottish system and how it works, within Scotland, in terms of healthcare, the National Health Service, or the NHS in Scotland, we have 14 territorial or regional health boards. So in other words, your regional health board is your locality board, and they provide services to you. So I am sitting over here in Lothian. I'm actually in West Lothian geographically, but Lothian Health Board provides services for me personally. Whereas I think, David, you're Greater Glasgow and Clyde, I would guess. So you're over here. So your health board is the main provider of services to you. That is not to say that you cannot receive services in other health boards across Scotland. That's not the way it works for us. You can, of course, but your first point would be your local health board, really. So your 14 territorial or regional health boards are then supplemented by what we call 8 national or special boards. And these are all legal entities. They are all managed through Scottish Government and through a series of contracts and through the UK Government as well. So our 8 national or special health boards are the boards that provide services to the whole country. So NHS Education for Scotland, the clue is in the title. They oversee the education and training programs for nurses, allied health professionals, doctors, dentists, etc. for the whole of Scotland. Public Health Scotland, again, the clue is in the title, is a national board, and they provide public health advice, services, guidance for the whole country. I can touch on some of these in a little more detail as we go on, but just that's the basic structure in terms of the NHS in Scotland. And hopefully my slide will change. All right, it's a wee bit slow. Not sure why. Okay, I'm just gonna try to go back one. Sorry, folks. Okay, that's slightly better. Hopefully you can see the slide has moved forward. Thank you. So in terms of central government delivery through our NHS boards in Scotland, what it covers our primary care services, so your general practitioners, your pharmacy, dental, and it covers your community care services, which are typically services provided more into homes and community settings. This would be a lot of allied health professionals working here, so physiotherapy, occupational therapy, etc. A lot of nursing services as well. And in actual fact, allied health professionals in Scotland make up a really significant part of the health workforce and provide a great deal of the services. And it also includes acute hospital services for short-term treatment, emergency conditions, accident and emergency, planned and unplanned care. Okay. That's not to say that we don't have some private care in Scotland. We do. We do have some private hospitals. But in Scotland, as opposed to England, the difference is Scotland private care is much less than in England and the rest of the UK. And there are relationships between the NHS, the National Health Service, and some private healthcare providers, especially around things like the delivery where there's high demand and waiting times. They might reach out to the private care providers, healthcare providers, to supplement the service delivery. But really the private services, just as in any other country, are typically provided through your personal insurance, health insurance that people may also acquire. So it's possible if you reside in Scotland, if you're a Scottish citizen, you could use your NHS, your National Health Services, for your day-to-day, but you could also have private healthcare insurance and use that for some things. But it's a much smaller part of the service delivery model in Scotland. Okay, so just a few facts again about Scotland, just to help you understand really what we're dealing with in terms of our health and care provision. As I mentioned, we have our 14 regional boards, we have our 8 special or national boards, and in terms of population delivery, currently the population base is 5.46 million, most recent estimates. We're seeing some growth in our population in Scotland, and that growth is primarily actually through inward migration, again, not dissimilar perhaps to other countries across Europe. Our healthcare budget, as you can see, is 19.5 billion in the last round of spending. Now, that healthcare budget, it always makes me smile a little bit. I'm assuming it's the same for you guys. We're given a set figure for the healthcare budget, but actually there's a lot of activity going on underneath that figure as to what's covered and what's not covered and what's recurring and what's next year and last year, etc., etc. What I would say in terms of our budget at the moment is that we are under a great deal of restraint in terms of what we can spend. We're going through a really tight period of financial period in Scotland in terms of the NHS. And we are seeing that reflected in national programmes, in some changes in national programmes, some slowing down of national programmes and shifting in priorities as well. In some ways, I have to say, maybe this is not the most popular opinion in my Scottish Government colleagues, but in some ways that's not a terribly bad thing for digital, because it actually pushes us a little bit further and a little bit harder. And what we have found most recently with our colleagues across the NHS, so Scottish Government talk obviously on a very regular basis with the chief executives of all the NHS boards, is that they are should we say, much more receptive in the last 18 months to digital initiatives, and not just digital first, but really trying to find more blended approaches to how we deliver services. So even though the financial situation is very difficult for a lot of reasons, it can actually push digital a little bit faster, we find. So in terms of general practice, as you can see, the numbers are listed on the slide. And the other thing I wanted to point out just is that significantly in Scotland, you know, if you think about the size of our population and size of our working age population, we have a very high number of people who work directly and indirectly for the NHS in Scotland, and also through our social service provision, a very high number of people. So in other words, what does that mean? In most local areas, you will have people who either directly themselves or through their family members are working for the NHS or the care services in some capacity. So it would be unusual that you would find a family who there isn't somebody who's connected through the NHS and social care services. In terms of the sense of ownership and participation in healthcare in Scotland, I would say generally, even though we're maybe not the most vocal as in other countries, in fact, somebody was telling me yesterday that Scotland is the only country in the last couple of years where there haven't been healthcare strikes. I'm not sure that's entirely true, but apparently the person who was telling me that was from the WHO, so I have to believe them, because we came up with a better pay deal than some other parts of the UK. But what it actually means is there's a very strong sense of ownership in terms of our health and social care services, and people get very pissed off, agitated, however you want to describe it, if they feel that services are being reduced or changed. So the other point from a digital perspective, probably worth noting, is that we've had a long-standing, coming up 20 years now, of various forms of policy around digital. And from a policy point of view, what we have found is that, broadly speaking, whichever political party is in power in Scotland, there is still ongoing support for digital in health and social care. That hasn't really changed. What has changed are the constraints and the financial capabilities to deliver on some of that activity. And I should have said actually at the outset, a small point, but maybe an obvious one, that since the Scottish Parliament came into being again in 1999, healthcare, like education, is a devolved issue in Scotland. So in other words, even though we are in line with UK policy and funding comes through the UK government, the decisions we make about how we deliver healthcare are different. And the decisions made and the budgeting around healthcare in Scotland are made by the Scottish Parliament. So hopefully that's helpful. Okay,
Nessa?
quick. Yep.
Can I just ask, there was a question whether the participants can get a copy of the presentation afterwards?
Yeah, of course, no problem. Yep.
Super, thank you.
So a quick question, just to make sure everybody's paying attention. I want to ask you, and you can put your answers in the chat, although I can't see the chat, so it's not a terribly serious question. How many islands do you think Scotland has? We're a small country, geographically, landmass, pretty small, but we have our archipelagos. Any guesses in the chat? I'm relying on Maria.
We've got 120 in the chat.
Well, actually,
120, yeah.
Unbelievably, it's 790. Can you believe that?
We've got a couple of winners.
I have to say,
some people that had time to Google it, probably.
Some people are more knowledgeable than me. As an Irish person who has lived in Scotland for a very long time, I am just astonished by that fact. But realistically, only about 80 to 90, you could say, have some form of habitation. A lot of these islands are not inhabited. But for example, the Western Isles along the west coast, off the west coast of Scotland, which usually are referred to as the Hebrides, the Inner and Outer Hebrides, if that's a more familiar terminology, and the Northern Isles, which would include Orkney and Shetland, they're the main populated areas. And you know, as a collective of islands, each of those groupings have a population of 20 to 30,000, but very widespread. And then obviously there are smaller islands as well. Okay, another quick question. How many local authority areas are there in Scotland currently? I say currently as if it's about to change. It's not about to change, although there are always discussions about how many we need. So municipalities or local authorities in Scotland, how many do you think? Any guesses in the chat?
We've got 100, 256.
I would say that's a very European answer. Our colleagues in Spain are astonished we've only got 32, for example. So yeah, 32 in Scotland. And here you go. Again, they are geographically organized. So my local authority is sitting over here. As you can see, I would be West Lothian to where I'm pointing. And the reason I'm just bringing that up is because when you think about how services are delivered, whether it's to children and thinking in terms of education, nurseries, care provision for children, care at home for children who may have complex needs, or whether it's through to services for older people who, again, may require additional support at home or even adaptations in the home, or if we move into technology-based support, things like telecare, assistive technology or welfare technology in the home, the alerts, the sensors, the monitors, all of that kind of technology, those things are typically provided through your municipality or your local authority. So there is an overlap between the health and social care provision for us. And it's worth saying perhaps at this point that in Scotland since 2014, which came into force really in 2016, we've had legislation for the integration of adult health and social care. So in other words, the budgets are meant to be joined and the delivery of services is to be joined, and how the planning and delivery of services works in each local area is meant to be a joined budget. So social care and health are not supposed to exist on separate islands any longer. You can see there's caveats in the way I'm saying that because it's been a slow and difficult process. Not necessarily because there's massive resistance, there has been some resistance, but really just the bringing together of fundamentally different organizations and systems and technologies has proven really complicated. So in addition to the sort of layers of management and organisation in Scotland, you have your municipality or local authority, you have your health boards, which I've mentioned, and between the two, now in Scotland, we have what we call integration joint boards, and that's where the representation from health and social care sits. And the social care side oversees things like typically the education, as I say, care provision, some of the telecare, welfare technology at home, and also things like your roads, your waste collection, your lights, street lights, and all of those other things. And why it's so important for us in terms of the integration and how these services are being delivered is really because we are seeing an increase in our elderly population. As you noted on the last slide, the over 65 population is increasing, whereas our younger age population, our under 14s up to 14, 15, is decreasing. And that working age population in the middle is struggling, actually. There's some increases in some areas, but in other areas we're finding it really difficult both to recruit, to train, and to retain staff, and especially in those island and remote and rural areas. That's a difficulty for us. So I'll try and move a little bit faster because I think I'm possibly taking a bit too long. So as I mentioned, Scottish Government is in charge of, responsible for how we spend our budget for health and social care. And these are the priority areas that we're looking at right now. I don't think any of these will be unfamiliar to you, but these are the responsibilities for the Cabinet Secretary in Scotland, but the individual priorities obviously under these will change. I also just wanted to mention the public health priorities because there's obviously a lot of overlap. And in the new programme for government, which I can share with you as well, which came out last autumn, each year, roughly, the Scottish Government produces a programme for government, which just a very high level document, which details our priority focus for the next year. And one of the areas in particular is around childhood, child poverty and well-being. Others would include economic development and also sustainability of services. So moving into a bit more around the technology and the way we are shaping our technology delivery and how we're thinking about technology in Scotland, it's worth pointing out that almost, it's gone up slightly, but almost 100,000 people received some form of home care in the last 4 to 5 years. We actually expected this to increase a lot as a result of COVID, and we were kind of proved wrong, actually. What we found was that family and local support services provided a really good backup, whereas we thought people might lean more on their welfare technology and assistive tech. Some did, but actually it didn't transpire that there was a massive increase in support required. So over the next 20 years, approximately, as I've said, over 65 population is going up. General population levels are decreasing slightly, but the disease burden goes up as well. What we find is that in Scotland, if you are over 65, there's a high percentage, 60 to 70%, that you will have one long-term condition, but more likely you will have between 1 and 3 long-term conditions. So that might be arthritis, for example, high blood pressure, diabetes. And combined, they're not necessarily insurmountable. They can be managed with lifestyle and medication and managed well, but it's one of the areas we're trying to focus on in terms of delivery of our digital support services, is really how do we support people to keep them well, keep them out of hospital, keep them independent, and able to live their life to their fullest. So in terms of digital and how we see the delivery of services, really around the policy side, we're looking at digital, not, yes, it's transformative, but we want it to also enable change. We want to think about how people use their own technology, and how we kind of leverage that then into more support and independence type activity for people who have those long-term conditions. We also need to do better and work harder in terms of the NHS recovery. Here, in the context of recovery, we're talking in particular post-COVID recovery for services. And obviously, like other countries, we saw a big impact on things like waiting lists for some acute conditions and long-term conditions and newly diagnosed conditions because of the closure and slowdown in other services as we dealt with COVID. And we're still dealing with the impact of that to some extent, but also recovery in terms of the typical service delivery and sustainability of how the NHS works. The other factor for us in Scotland is that we have to think about the integration element, as I mentioned already. And even though it's proving challenging, we are really starting to come to grips with how do we perhaps deal with an integrated record for social care and health. So for example, maybe a slightly simplistic example, but if I'm living at home and I'm an elderly person, but I happen to be frail or have arthritis and difficulty with mobility, and I fall at home, as long as I'm not taken to hospital, that'll be part of my social care record, but it won't necessarily be part of my NHS record. And the problem arises when people with long-standing conditions or newly diagnosed conditions turn up in hospital in an emergency department, and the hospital staff are looking at their record thinking, well, we don't know how long this person has been gradually declining at home or what other complicating factors there may be. So this integration of the record is a really big feature in terms of our priorities at the moment and how we do it. Yes, we're well aware that other European countries have moved much further, much faster than we have on this one, but it's something we absolutely need to tackle. So there's a lot of work going on around that. The other areas, just to point out in terms of how we use data and share data, such as the integrated record, are around what we refer to as a digital front door in Scotland. For other countries and regions, the idea of a citizen portal might be more familiar. So how does a citizen use a single point of access? Now, it's slightly misleading because it's not that in Scotland we don't have, web-based and online service models where we can provide accurate, credible, reliable information about health and care services. We do, but what we don't have is that service joined up with other elements of the system, providing a much more widespread access to information and also your own personally held information. So that's the bit we're trying to work on. And governance and standards, information standards, is always a challenge, but that's actually an area we're also particularly looking at for the expansion, because you can't do one without the other, really. You can't expand those services without the governance and the health insurance of information. So we want our citizens to have access to and greater control over their health and care data. We want that to be more accessible in terms of how people access it. It's not that I can't go to my GP and get my data and get access to my data. I can, but it's quite a, it's a slow and awkward process. I don't have access currently through an app. I have access to limited information from primary care online for myself. I'm using myself as an example, but I don't have access to all of the potential information I could. And again, we know that's an area that Scotland needs to improve on. And we want our services to be people-centred. In other words, what are the priorities, not just for the NHS in terms of conditions and demands, but what are the priorities for our citizens? One area which I think we do well in Scotland is, and have done well in, is through the use of co-production and co-creation as models, and what we call in Scotland the Scottish approach to service design, where we do genuinely, go and talk to people and sit down with people and listen to people and ask people their opinion. And that, as you know, I'm sure that can be challenging. People don't always say what you expect them to say, but we absolutely know when it comes to the sharing of information, vital information for health and care records, that is something that people are on board with. And how do we support it from a clinical point of view? Work is underway and has been underway for a little while now around what we call our national digital platform. So it'll be like a single point of access for healthcare staff working across the NHS. Excuse me. So I'll speed up a bit. We're looking at all of these different aspects that relate to how we deliver. None of them should be terribly surprising. We need to have the workforce, the capabilities to do it. We need to have the secure infrastructure to provide the sharing of data, and the ethical approaches that really brings in how we communicate with our population, how we work with people through things like digital citizen panels and other ways of talking to people about what we're doing and ensuring that public are on board. I just wanted to briefly mention also the telecare landscape in Scotland, although I don't work in telecare. So as I mentioned earlier, telecare is typically, or welfare technology, typically provided through your municipality, through your local authority. And while there are about 140,000 citizens across Scotland in receipt of a telecare service at the moment, the majority of that would be really basic telecare provision. Excuse me. Basic is not, it's not a negative thing. That's what people want. That's what people require. So it might be things like fall alerts, sensors in the home, particularly sensors for people who may be vulnerable, frail, have a disability, etc. There's really a wide range of potential technology that can be used. One of the main focuses for our colleagues working in the telecare side of the activity has been around the digital switchover, which has been happening across the UK, as you're probably aware. So we have to, shift how we provide the services from the old telephony-based systems. Okay, I'm just going to move on. How do we think about how we deliver all of these things, whether it's digitally enabled services or whether it's some more socially care-based services, if I can put it like that? In Scotland, our reference point really is our national health and wellbeing outcomes. They're listed here, and obviously you can see more about this on the slide. Just a quick point to say the health and wellbeing outcomes evolved over a number of years and are used as a standard. There are other local frameworks and there are other key performance indicators and there are other annual targets, of course, across services. But the wellbeing outcomes have been developed with colleagues from health, from social care, from third sector, from public health. They take into account things like the sustainable delivery goals, which you may be familiar with, of course, and other international standards and benchmarks. So these are more about how we aspire and what our ambitions are in terms of how we deliver health and care services in Scotland. Okay. And in terms of our health and care innovation ecosystem, I would say We have a strong collaborative record in Scotland. A lot of the services that we deliver are perhaps a bit different from some of our other colleagues. A few months ago, we had a group from southern Denmark actually visiting us, looking at mental health services. And it struck me, and it struck the group visiting, that one of the things they were really surprised about was the intense level of collaboration between third sector organisations and NHS organisations, housing and local authorities in the actual delivery of services. So what I mean is third sector organisations can often be delivery partners, and that kind of collaboration, partly because of the integration model that we're trying to work towards, and partly just because we are a small country with limited resources and we know we have to do it together in order to get services delivered. That's actually something that people generally adhere to and sign up to and are in, no difficulty with. So even though there can be, challenges about who holds the budget, etc., that's normal, typical things. When it comes to innovation and when it comes to delivery of digitally enabled services, we don't find a major difficulty in collaborating with our partners, I would say. The routine issues arise, but people are kind of signed up to the fact that we have to work together. I'm not going to talk about Scottish Enterprise and Scottish Development International because that's not my territory to talk about. But I would just mention that Scottish Government also funds a number of innovation centres in Scotland, including the Digital Health and Care Innovation Centre and the Data Lab. And we're also focused on around sustainable delivery of services. So we're trying to think about how do we, unlike in some other regions and countries where I've seen, in Scotland, we're really trying to look at how do we scale up and make national good digital innovative developments. So rather than having local pockets of excellence, which is nice and good, how do we actually take that and scale it up nationally? And that's the remit of Centre for Sustainable Delivery and some of my colleagues working there. Our colleagues in CivTech, which again is funded through Scottish Government, also have an accelerator programme where they work with new and emerging SMEs and not even quite at SME stage to respond to challenges that they issue on a regular basis. They just completed a challenge call in December, I think, with the interviews for that. And there'll be a new challenge coming a little later in the spring. So they invite people to respond. And actually, worth saying, you don't have to be in Scotland to respond to a CivTech challenge. And I could share the link to that for you as well. So yeah, collaboration is overall the ethos for the way we work. In terms of our digitally delivered services or digitally enabled services, we know we've got a long way to go in terms of the things we can achieve. But in terms of the practicalities of what seems to be working well for us, I would say, significant success, particularly around mental health and wellbeing services, which is driven by the demand in the system, which is a good thing, not driven by the technology. But we've managed to embed that as a nationally accessible and deliverable service. I think 40% of our psychology referrals at the last check were to digitally enabled services. So that's something that we're working really hard on. And we want to expand in areas where their services are delivered to the individual or to the home. We do have a significant remote health monitoring program in Scotland for people with long-term conditions, but again, it's an area that needs to expand. And all of those elements that fit into the digital front door, the citizen portal, and backing it all up then is the data and the potential for the integrated record. So I'm sorry if I've gone too long. I can share the data strategy. There will be an update later in the spring, but I can share the data strategy as well. Final question, just to make you smile. What do you think Scotland's national animal is? This should be easy, actually. But again, always a surprise to me. Any answers in the chat?
We have a unicorn.
Yeah, and a cow.
And a cow.
Highland cow.
Highland cattle.
It is a unicorn, and that is an absolute fact. The national animal of Scotland is a unicorn. There you go. Well done, whoever got that. Okay.
Nessa, we have. Are you
I'm done
now? Or
yep.
Because I have a question from. It says TW. What is the name for the equivalent of the UK HSA for Scotland? Do we have one?
UKHSA.
UK Health Security Agency, sorry.
Oh, in terms of cybersecurity for the NHS?
I think it's for like any sort of like they're doing all the tuberculosis case monitoring and like monkeypox and everything else.
Oh, that would be through Public Health Scotland, really.
Yeah.
The National Surveillance Centres would be based at Public Health Scotland. But one of those national boards that I mentioned there at the beginning is Public Health Scotland. The other is NHS National Services Scotland, who I also work with. And between the two, they collaborate very, very closely. I mean, it's literally kind of minute by minute almost in terms of monitoring and surveillance for conditions. I can probably share my screen if I can get the right URL and show you the dashboards they use. There's a lot of publicly accessible information when it comes to surveillance of new conditions, flu, etc., things like that. Yeah. Public Health Scotland would be your first point of call. I hope that answers.
Thank you, Nessa.
Okay, I'll stop sharing and I'll put a couple of links into the chat.
And David also put in the link for the
Public Health Scotland.
Public Health.
Thank you, David.
Then there's
It
another
looks like
question. Yeah,
yeah, sorry. No, you go, Anna. Apologies.
Okay, there's another question here. What is the option for cloud hosting of data in Scotland?
I knew you were going to ask me something I couldn't answer. It is an option, and our colleagues who are working on telecare, on the provision into the home, technology in the home, the new alarm receiving centre model that they're using, cloud is very much part of that. Cloud in terms of the NHS, yes, some developments, but it's been, I think there have been challenges, it's fair to say, in terms of how far and how fast we can go, because it's not just a case of, forgive me if this sounds really simplistic, it's not just a case of saying, yes, the cloud is a good option, a reasonable option, we should use it. The actual data and data quality and the frameworks around the information governance insurance side have to be in place as well at the same time. And it's the bringing together of those two things, if that makes sense, to shift to a cloud-based model, that's been tricky. But we see it working right now in terms of the telecare and the shift in the alarm receiving centres. When I mentioned the digital shift in telecare from analog to digital, and it is working in some parts of the NHS, but it's something we need to expand. Yeah, but I can get a more technological answer for you from one of my colleagues working on that, I'm sure.
Okay. And what about storing outside of Scotland, not in the cloud, but like in Sweden, for example?
Yeah, a lot of agreements and discussion has to take place. I won't even try and give a proper answer to that, because I might get into ground that I'm not sure of. But yes, it's possible. But we have post-Brexit, that's particularly a challenge, I would say. So yeah, a lot of discussion and agreement has to take place on that one. I'm sorry if that's not a complete answer, but I can ask one of my colleagues working on it. Right, I'm just going to try and share these links in the chat.
So any other questions from the audience?
Thank you for the chance to speak to you. I hope you have a lovely visit when you come. I don't know if you want me to stay, Anna, or if you're...
Well, we're just going to go through the draft program for the delegation trip. So you can stay if you want to. Maybe some people will think of something to ask, but also perhaps we can get in touch with you afterwards. I see Clive has his hand up.
Yes.
Oh, and
Hi,
Jan
Anna.
as well. Yeah.
Hi, Anna. Thanks.
Okay.
I just had a quick question, Nessa, and that is about internet accessibility throughout Scotland. Is that do they have the right speeds? Do they have access? So if I mean, we specialize in mental health and well-being. So everything around that, obviously, if you want to connect, you need to know you've got connection, especially in, like suicide ideation and all that kind of stuff.
Yep. Actually, I would say that's one area where we have been doing pretty well. Typically, this is not the exact figure, so please don't quote me on it, but typically you'd be in around 80% in terms of access. But what we've tried to do for the mental health service provision and for others is to ensure that if people don't have access directly into their own home, so for example, a lot of the CCBT, Computerized Cognitive Behavioral Therapy program, which has been really successful in Scotland and is available in all 14 health board areas. Therefore, you're taking into account really rural, remote island communities as well. It is accessible. If people have trouble accessing it into their own home, what we've tried to do is make partnerships with local community-based facilities. So that could be a library or could be other community-based services. So that has worked really well, actually, and we haven't had a major issue with that, I have to say. There is a separate program underway through Scottish Government, which doesn't come under the Health and Care Directorate, but is the Digital Directorate. It's just called the Digital Directorate, and their focus, or one of their main focuses, has been around broadband rollout and expansion of services and speed, internet speeds, access, etc. So we try to work in parallel with them as well. But yeah, it's not always easy, but we know that, you know, according to Ofcom, which is the UK, you're familiar with Ofcom, I'm sure. They say that broadband, super fast broadband access across Scotland is over 90%. But realistically, I would say for some of the pockets of really rural areas that we have, you're probably looking more at between 80 to 90%. Yeah.
Okay. And that those rural areas, do they have, if they don't have broadband, they have cellular connection?
Yep, and actually what we're trying to look at is, you know, the idea of people, as I said, if access into people's own homes, so using their own devices to provide services through secure networks. I can show you or share with you as well. There's a nice map which shows you how people access video consultation services, especially in rural areas. So again, that's an area where it's not computer-based CCBT or online programs for mental health and well-being, or apps, which is another area that we focused on, which is their own devices, obviously. But we've also worked with community centres and libraries to provide access points for video consultation for people who need video consultation for the NHS. And that would particularly take in remote and rural areas. And that's working well. And we're seeing group consultations as something that's actually expanded for those kinds of services. I don't know if that's something that you're typically involved in, but there's a lot of interest in group consultation. So for example, if you run a support service of some kind, or antenatal services where you typically could have maybe 10 women in one room receiving a support service. If you can do it online and you can do a group-based service, you could have 100 women receiving the same. So there's efficiency in doing it that way.
We can do group to group either way, both with a clinical team and or group patients. That's the same as well. So it's all managed through the calendar.
And we see a lot of interest in that, actually, and particularly from a user point of view, it's very popular, but also from a staffing point of view, when it comes back to those objectives around you know, more individualized, personalized care, which focuses on well-being and independence and self-care and self-management. A lot of education and training, particularly around long-term conditions like diabetes, has been very well delivered using those, and is being delivered using those kinds of group virtual programs. And the service we use, the Attend Anywhere service in Scotland, it's a national license, so it's free to use for staff. And that's how it's been delivered for the last, gosh, 7 or 8 years, I think I want to say. So it isn't a free for all. The individual practitioners can't decide which video consultation service they want to use and just launch into it. They have to go with the nationally approved license and model. So there's that. Maybe some regions or countries don't do it that way. Obviously, I know they don't. But in Scotland, the view is that if we can embed it and provide support at a national level and licensing, that that's a more sustainable way to deliver. And then the guidance wraps around it and the security wraps around it. So,
Good.
sorry.
No, that was really well answered. Thank you very much.
So we have one more question. John, sorry, I think maybe you were first, but please have a go.
No problem. Thank you, Anna, and thank you, Nessa, for a great overview of the Scottish healthcare. I represent a company called Non-Light Diagnostic, working in the reduced time for depressive patients to get them on right treatment. And except for all the good benefits for the patients and the relatives, there's a financial part of it. And my question is regarding reimbursement for the operational units or the care units. You have the primary care, you have the acute care or specialist care, and the community care. Are these institutions or these operational care units, are they reimbursed from the same source? You mentioned that you had the national funding or UK funding initially, but when it comes down to your national board or your local authorities, who's actually dealing with the reimbursement? That's one part. And the second one is there any activities to have separate reimbursement for use of digital support systems in the care process?
The answer to the first part is it's nationally provided. So I'll use myself as an example again, because that's probably the easiest. If my general practitioner is my usual access point to all of the services. It's not like in some other European countries where, if I need an orthopedic consult, I go and make an appointment with a specialist orthopedic and etc. And I pay for that through my insurance or however I pay for it. In Scotland, typically, and for almost everybody, almost all the time, there's always going to be little caveats. I go through my general practitioner, and my general practitioner will refer me to that orthopedic consultant. I can, if I have private health insurance, go through my private healthcare provider. I could do that. Most people don't do that. They go through their general practitioner. It is paid for through my normal insurance that I pay as part of being, a citizen and an employee working in Scotland. So that's maybe a clumsy way of answering, but it's paid for because I am a citizen here in Scotland. I don't pay anything for those services. If I have private healthcare insurance as well, I pay for that myself. And that normal model of payment of accessing services, whether it's everyday services, my kid might get sick and I have to take them to accident emergency. My elderly parent might require a long hospital stay and a hip operation. I might require ongoing treatment. All of that I don't pay for. It is paid for through our NHS. However, some things are not on what we call on the tariff. In Scotland, it is different from England. There is much more covered in Scotland. Things like medicines, especially, are covered more in Scotland than they would be in other parts of the UK. Personally, the medication that I receive on a regular basis, I don't pay for it. And it's not paid for typically in Scotland unless it's a very complex or new medication that's required, and then an agreement will be made with your local authority. So the money will come through your NHS board and or through your local authority if it's an element of care provision. However, it's worth saying, if I decide that I want my elderly parents to have an assistive technology support in the home, and I go to my local council or my municipality and say, I'm interested in having these types of technologies put in the house for my parents, there is what we call a sliding scale payment. So the family, in that case, the family will be asked to pay, and it could be as little as £5 a week. It could be more, it depends on the amount of technology that's required. So people are not paying for the technology. This is maybe a tricky point. They're not paying for the equipment going into the home. What you're actually paying for or contributing to, because you're absolutely not paying the full amount, what you're contributing to is the care service that is behind that technology. So it's the call out of staff at 4 a.m. or the ambulance service or whoever it is that needs to be provided. So typically you don't pay for personal care in Scotland, but if you have personal care and you have technology support in the home, there is this sliding scale payment. Not everybody has to pay it, and it can go up or go down depending on the level or the intensity of provision that you require. And that would be local authority, but almost everything else goes through your NHS. And when it comes, I mentioned integration, when it comes to the budgeting, the budget is jointly held. And that was one of the most important points, I think, really around integration, is that the decision of who pays for what, let's be blunt about it, because, you know, the money is always the challenge. Who pays for what has to be jointly decided in those cases. It's not that it isn't complicated and difficult, especially in recent years. The idea of free personal care is a challenge for us. It's significantly a challenge, especially when we live and work in an environment where increasing taxes are not politically acceptable. That's probably the politest way I can put that. But on the other hand, in Scotland, people's expectation of and demand for free NHS access. If you have a teenager who's a student in Scotland, they'll get free access to the NHS as long as they're registered as a resident here in Scotland and have a general practitioner signed to them. They will get access to all of that. If, you know, touch wood, unfortunately, they end up in an accident, they get admitted to hospital, on the whole, they won't be charged for anything. And that's a hard model to deliver, especially these days under the demands that we have on the system. So there's a lot of kind of grumbling in the background about how do we do that better and how do we resource that system better. But actually, again, in a very small way, I think that opens opportunities for the provision of digital, because if you're providing services to people directly through their own phone or through their device in their kitchen, you're reducing the pressure on hospital-based and clinical-based services, but without reducing any of the quality of service. I think there was a point in the chat about elderly care.
Yes, so David answered that, but if you have
Nessa, yeah, I hope that's okay. It was, have a
Super.
look and you might want to add, it was that the provision here is pretty mixed.
Yeah,
And
very mixed, I would say, in terms of, I think there are about 1,300 care homes across Scotland of all different types. A lot of them are run through local government with a collaboration with the third sector or charities. They're a mixture of private, yeah, absolutely, David, private and local government. The care at home approach, again, is another way to try and counter that. It's maybe not the topic of this webinar, but I would say in terms of care homes and care provision, whether that's for, you know, young people with acute illnesses, physical, mental, etc., or for older people, more typically, we're seeing a real crisis in terms of workforce for the care sector, more so than health, I think it's fair to say, and especially in remote and rural areas. One of the things we did during and after COVID was to try and introduce more technology into care homes through funding from Scottish Government, and that worked actually really well. Tried to increase, because a lot of care homes didn't have very good technology infrastructure, but tried to support them to improve that and support communication between care providers, so the care home setting, and hospital and other care providers as well. In terms of how, sorry, David.
I was going to say, we've also done it, and I don't know if you've seen similar in Sweden or elsewhere in the Nordics. We now have a higher minimum salary within the care sector. So that's changed probably in the last 2 years. So it's actually probably nearly a third more than our minimum salary, just to try and increase and keep people in the sector. So it's about 12, nearly £13 an hour. And I think our minimum is about 8 to 9, depending on age.
And I would say, I'll put the link in the chat. There's an organisation called Scottish Care. Scottish Care is the umbrella organisation or the member organisation for care homes, care providers in Scotland. And what we see here is that third sector organisations and organisations like Scottish Care have overall actually have a really good working relationship with Scottish government, and they're involved in a lot of the discussions about how we move forward. Of course, we all have very different points of view about things, but they are involved in the conversation, and we try to take on board all these different perspectives, because ultimately they're just as important as everybody else in that kind of care landscape and how we manage it.
I think we need to stop here.
Yes, sorry.
There seems to be a lot of great interest in Scotland, which of course we love to hear, us working with Scotland or being Scottish. So so thank you all, guys. But we also need to talk a bit about the delegation that is going to that we're planning to go to Scotland in April. Thank you so much, Nessa, for your insight. It was absolutely amazing.
Absolutely.
So, Anna, can you please?
I'll share that.
I was just going to say, if people have further questions, or if questions have not been answered, if somebody wants to round them up, I'm happy to try and respond or direct them to the right colleagues who can respond as well. But thank you very much, everybody, and thanks for listening.
Thank you so much.
Thank you, Nessa.
Thank you.
And thank you, David, also for supporting.
No, thank you, guys. Take care. All the best.
Take care.
So we have this upcoming delegation, and we have been discussing it for some time. And actually, the story behind it is that there are these innovation pathways which Scotland is proud of, and they want to share, but they also want to understand how we do it in Sweden, and also, of course, other countries. So that's why we have planned this delegation. So it's not really maybe focusing on, exports or pitching and selling, but on building contacts, relations, and understanding, sharing knowledge of how we do things. And it seems like we have a lot of things in common. Our healthcare systems are in many ways fairly similar, and I think we face the same challenges with an aging population, which per se isn't bad, of course, but it entails some challenges. So I think we would have a lot of opportunities to have interesting discussions. And basically the thematic topics for the visit is innovation, collaboration between public-private sector and research, academia, and NGOs, so triple helix collaboration, and sustainability in healthcare. So I'll let Marianne go through the program. It's not really, we don't have all the details, but at least to give you an idea of what we will do during these 2 days.
Thanks, Anna. Yeah, what we are planning is for an arrival to Edinburgh just after noon. I mean, just around 12 p.m. On the 9th of April. And that is possible from whether you come from Stockholm or you're traveling via Copenhagen. That is doable. And we will start with an introductory session where, of course, you will be welcome to Scotland, but also where you will learn a little more about the healthcare system and the priorities. Some of it will be what Nessa also already told, but there will also be additional information. And focus will be on inequalities, lifestyle and chronic diseases, prevention. We haven't really touched upon that yet. Distance to treatment and clinical visit is to be TBC. We're definitely working on arranging a clinical visit. After that, there will be a transfer to the hotel and check-in, and we're having a welcome dinner, a great opportunity to network both with Scottish companies that will also be there, but Scottish authorities and decision makers. Yeah. And on the next day.
Yeah, sorry, here.
That's all good. Here you can see the the focus areas or the themes that Anna mentioned, the triple helix in healthcare, adoption, innovation adoption, and sustainability. So those are the themes that we will be working on. And the plan is that we will end around 2:45, which should make everybody able to get to the airport in time for flying back to Stockholm or Copenhagen. Yes. So this is a very brief description of the program, and we hope that you'll find this interesting and would like to attend. That'll be super great.
Yeah.
Thanks.
So thank you, Marianne. So we will be sending invitations. We're still figuring out the budget and some few things, but we can send a save the date and then come with more detailed information in a little bit. So I will also send the recording to everyone who has registered. And yeah, thanks for all these great links, which I think you can access afterwards. And we'll ask Nessa to send her presentation as well, so we can share that. So thank you a lot for joining us, and hope you will also want to join us in Edinburgh in April.